Good evening, one and all. So, today evening, I have chosen a topic. Before it comes knocking at the door, we should be prepared and we should be ready to face it because it is already started happening in our neighboring country, and you never know when it comes knocking at our door. So, today's topic of discussion is monkeypox. A brief overview, it belongs to the genus of orthopox viruses. The related viruses are variola virus, which causes smallpox, then the virus from which the smallpox vaccination was made, Vaccinia virus, cowpox virus, comes in two strains, the Central African clade and the West African clade. The Central African clade is the most virulent of the two. A brief history. It was initially discovered in 1958 in the captive monkeys who were used for research purposes in Denmark. In 1970, the first human case was reported in a 9-month-old child in Democratic Republic of Congo. Subsequently, in 2022, there were outbreaks in non-epidemic countries, and hence WHO declared it as a public health emergency of international concern. So, after this, again in 2024, we have got outbreaks in non-endemic countries. So, again, it has become a major concern for us. So, primary reservoir, as the name suggests, the primary reservoir should have been monkeys, but apart from the monkeys, the primary reservoirs are squirrels, tree squirrel and Gambian pouch rat. The squirrels are the main primary reservoir of this virus. And secondary reservoirs are the primates, which includes the monkeys and apes. So, how did this disease got exactly transmitted from animals to humans? So, animals to humans, the transmission can be from blood, from body fluids of infected animals, and when an individual comes in contact with the cutaneous or the mucosal lesions of an infected animal, mainly rodents and primates. Secondly, it can occur due to consumption of meat of the infected animal, undercooked meat of the apes and squirrels. Now, how does human to human transmission occur? This is very important to understand, because until and unless we understand how to human transmission occurs, we will really be not able to stop the virus from spreading. First is direct contact. Like if you come in direct contact with the patient, with the infected sores, scabs, body fluids, so there is a chance of getting infected. Respiratory droplets via prolonged face-to-face contact. And when does this occur? If the person lives in the same household or in the healthcare settings like us. So, if we are in contact, there is chance of aerosol contamination and then subsequently respiratory infection. From fomites, the fomites on which already this infected scabs have fallen, or there has been a contact with the body fluids, and then you touch these fomites, which are generally clothes, linen, your bed sheets, pillow covers. So these are the ways of transmission. Close intimate contact. It is not a sexually transmitted infection. However, because of the close intimate contact, there are chances of it getting spread through the respiratory oblique body secretions. Congenital infection, it can be transmitted from mother to fetus through placenta, and it may lead to congenital monkeypox. So, a brief overview about the course of the illness. Like any other viral illness, what will happen? First is the incubation period. If we talk, roughly around 2 weeks of time, a fortnight's time. It generally ranges from 5 to 21 days. The prodromal stage, it lasts from around 5 to 7 days. just remember it, it is just like dengue fever except for the lymph node part. So predominantly fever, headaches, myalgia, back pains, swollen lymph node, and followed by prostration and exhaustion. Now, after all these things have gone by, then the starts the period of eruption. The classical monkeypox skin lesion starts to erupt. It generally begins from first to third day after the onset of fever. Now, the thing to remember is the lesion initially start on the face. Initially it starts on the face and then it spreads to other part of the body. So one of my friends at Illinois got this lesion, and I'll tell you what he told me. Then this lesion spreads from, as any other pox lesion, it forms from macules, that is a red erythematous area. Then from macules it becomes papules, papules to vesicles, and vesicles then it gets filled with fluid, and finally it becomes scabs and fall off. Always remember, these scabs are infective. Now, these are not in various stages of development. The rash over here occurs synchronously, meaning the lesions are the same in the same area. The stage of the development is same in the same area. Then finally, within next 2 to 4 weeks, this scabs eventually fall off and dies. So coming back to my friend who got this monkeypox, what he said was it was one of the horrible night of his life. When the lesion appeared on his face, it was very painful, and it was so painful that it didn't allow him to sleep. So how do you diagnose? The diagnosis is done by PCR. It is a DNA virus. The gold standard of diagnosis is by a PCR testing. So from where do you will do the PCR? You have to take a needle, raise the lesion, and take the lesion in a sterile water container and send it for PCR. So it can be done from the skin lesions and from the blood. Serology can detect antibodies IgM, IgG, but because these antibodies cross reacts with various other pox viruses, so it is not of much clinical importance. Viral culture again depends upon the availability. The additional method to do is electron microscopy from the skin lesion or histopathology of the skin lesion. So again, those things, more or less, these things will not be available in majority of the centers. So once now you have come to the conclusion by looking at the clinical condition, the classical rash, and maybe you have done this thing. Though how do you treat the patient? Just remember one thing: the rash that you see over here are much larger than the rash that you find in the chicken pox. Much larger. So this rashes generally requires some dressing. So what you are going to use for dressing? You are going to use miflosin and fusidic acid. These are the topical ointments recommended in dressing of monkeypox lesion so as to prevent supraadded infection. The genital lesions are very painful, and doctors do recommend sitz bath. The the oral lesions are supposed to be, we should be using topical anti-inflammatory gel with some local anesthetic property. So how do you use pain relief in lesions of monkeypox? Firstly, topical ointments like Emla. If you don't have Emla, do try to use lignocaine cream. If subsequent to that, we can use antiepileptics like carbamazepine and pregabalin. Carbamazepine, we can go up to doses of 3600 milligrams per day, and then lidocaine patches can be utilized for pain relief of the lesions. Now these lesions do get complicated by supra-added infections. So from day 3, you may start antibiotics like augmentin, 625 milligram TDS, or you can use cefixime, 200 milligram BD, and maybe continued for 4-5 days till the time the scab falls off and the lesion dries up. Now coming to, are there any definitive treatment? Do you have any definitive antiviral? Tecovirimat, if you find it very difficult to remember the name, is specially targeting this orthopox viruses. Tecovirimat, very easy to remember by the name T-pox. That medicine will be available like this. And what it does is exactly it inhibits the viral protein, so it does not let the virus exudate out from the infected cells, and then it helps the virus to be limited to the infected cell, and it does not let the virus to infect the normal cells of the body. So the drug to remember today is tecovirimat, but it will not be utilized in all the patients. Generally, it will be utilized only for the immunocompromised population like HIV, solid organ transplant, malignancy, and maybe a few cases of uncontrolled diabetes. And of course with patients on immunosuppressive therapy because of either rheumatological illness and all. So how are you supposed to give T-pox? T-pox is available in 200 milligrams tablet. So the oral dosing will be 600 milligram twice daily for 14 days. The IV preparation is also available. So the dosing will be 200 milligram twice daily for 14 days. So what are the complications that we expect arising out of monkeypox, which has been reported in worldwide? Firstly and foremostly, bacterial infection. If you see, this lesion has been infected. The causative organism are generally Staph aureus and Strep pyogenes. It may lead to bronchopneumonia, sepsis, encephalitis. Yeah, corneal infection is one of the major thing that you have to look out for. So in case if the person develops a red eye, please take the help of ophthalmologist. It may cause keratitis, uveitis, corneal ulceration leading to loss of vision. So do put the patient on moxifloxacin eye drops. You may give them cycloplegics if the facilities of ophthalmologist is not available. And the steroids are only supposed to be used by ophthalmologist. This I am talking about topical medicines, not oral medicines, topical eye drops. So we come to case fatality ratio as to how dangerous is this disease. Minded, we already discussed about two of the strains. So if we talk about the Central African clade, case fatality ratio is around 10%. About the West African, it is around 1 to 2%. So what is spreading right now is this one. So even with this, like 1 person in every 100 is going to go nahi. So current estimates of overall case fatality ratio is between 1 to 10%. So coming to the end of the discussion, are there any vaccines available? Oh yes, ACAM, which was originally developed for smallpox, it contains a live replicating Vaccinia virus. It has been made available for use and for monkeypox. So it is a single dose administered IM by a bifurcated needle, And that is all that I can say right now. The availability of the vaccination is right now not there. However, I think if there is an outbreak, government is going to do something about it. But oral antivirals are definitely available. And so I have come to the end of the small talk today. Thank you so much. Good night.